write answers in the textbooks or in the classrooms. So the topic is sterilization and disinfection of our equipment, what we use day in and day out. So we're going to listen from the experts. We have 4 very good speakers for this program. Of course, the convener for this program, Dr. Karthikeyan, has made a very wonderful program. I invite Dr. Kritik Veluswamy, Dr. Kavaljit Kaura, Dr. Balgopal Nair, and of course, Dr. Abhishek, who always tells us something very interesting, and he's going to talk on future of urological sterilization. So I welcome all the speakers. I hope we have a very good program. Before I hand over to Dr. Karthikeyan, the convener of this program, I request Dr. Keshavamurthy sir, President, Urological Society of India, to give a brief address.
Thank you, Dr. Surya Prakash, and good evening to all of you. Welcome to this another edition of the ISU Smart Learning Program. As Dr. Surya Prakash told, this is a topic which is not very much discussed. Although we practice every day, we don't discuss much of it. We think we are doing the right thing and continue to practice what we have been doing all this. And today we are here to know more about that, whether we are doing right or we doing wrong, or should we do something else to the instruments which we handle. So Karthikeyan has put in a good program and an excellent galaxy of stars, star speakers for all those topics. I hope the session will be interesting and all of you will benefit from it. All the best to all the speakers and all the best, Karthi. Over to you, Dr. Surya Prakash.
Thank you, sir. Now I request Dr. Uttam Mete, sir, who is Honorary Secretary of Urological Society of India, to give his opening remarks. Sir, you are muted.
Yeah. Now I am made it unmute. So, good evening, everybody. Dr. Keshavamurthy, the President of Urological Society of India, Dr. Surya Prakash, the Chairman of ISU, and of course, the distinguished faculty for this smart learning program. I should say this is not a smart learning program. Today's program is essential learning program. This is must. So this is not a smart one. It's an essential, because see, I believe most of the urologists will be practicing endourology and nowadays along with that the robotics, and that includes both disposable and reusable and non-reusable instruments, and we should know how to sterilize them. Ultimately, we want to deliver the best of health care to the patients, and for the best of the care, it is not only the surgical skill and knowledge of the surgeon, because surgery is just teamwork. So you have to have, I think I would have been happy if some sort of technical persons or nurses would have also been involved in this program, because they are the one who are responsible for sterilizing these instruments and equipments. We may be knowing it, but we are not sure how to ensure that it is being properly done. So maybe that would have been a little bit better, but it is not possible. But with this, I think the distinguished faculty will actually do their job. And this is, and welcome to this again. This is the essential learning program. With this brief introduction, I hand it over to Dr. Surya.
Thank you, sir. As I want to tell again in every program I tell, this program is recorded. So anyone who misses for some reason can watch this program. You can even pass on this video to your theater staff or nurses, as sir was telling, technical staff, so that they can get some knowledge from this. Thank you, sir. Now I hand over to Dr. Karthikeyan, who is the convener of this program, who has devised this program, and he has made some very practical questions. These are the questions we need answered from the speakers. Over to you, Dr. Karthikeyan.
Good evening, everybody. On behalf of USI and ISU, I welcome all the faculty members and the delegates for this USI-ISU Smart Learning Program. Most of the time, we spend time in learning surgical techniques and learning the newer technologies. But today, we are going to learn about the most important aspect of patient outcome, that is the sterilization of instruments, which happens after our surgery. That is the reprocessing, disinfection, sterilization. I am sure the esteemed faculty members in the next 90 minutes will take us through our aim of the program, that is sterilization and disinfection. So without much ado, I will move on to the program. I will now invite Dr. Kritik Veluswamy from Coimbatore. So he will be talking about instrument processing in endourology, practical pearls from the OT to the CSSD. And don't miss the final 20 minutes about the practical question and answer session. Over to you, Dr. Kritik, sir.
Thank you, Karthik. Can you able to see my slides.
So you are audible and visible, sir.
Yeah, thank you. Good evening, respected professors, friends, and my colleagues. Before I begin, I would like to sincerely thank Urology Society and our president and secretary and president of ISU and Karthik for giving me this opportunity. So the topic today is instrument reprocessing in endourology, practical pearls from OT to CSSD. I have no conflict of interest. Why this is very important? Because in our day-to-day practice, we are using so many instruments. The purpose is that we should not give cross-contamination to patients, any infection. Aim is to protect instruments from damage, and this will increase the longevity. So who should ideally do? Ideally, a surgeon who is doing the surgery should do this. At least they should know how to clean the instruments. But most of the time in our practice, it's not possible. So at least a senior urologist staff nurse who is well trained should know how to do this, because it's a highly specialized process and most of the instruments are costly and delicate. And so if you don't do inadequate adequate cleaning, then it may lead to transmitting infections from one patient to another. It's a surgeon or the senior nurse who is the one who knows the exact structure of the endoscopes. They are the one who knows how to give special care and how to identify the damage. And if there are any early signs of wear and tear, then they can recognize this instrument damage. This will prevent the equipment failure and also avoid expensive repairs rather than giving it to some junior staff nurse or some junior colleagues. So these are gentlemen, Spalding is a microbiologist from Temple University who devised this classification. We divide into three: high are critical, semi-critical, and non-critical instruments. High is the one, any device which is involved in open surgical cavity or entering the sterile vascular space. Semi-critical category involves any device that comes in contact with intact mucous membrane or non-intact skin. Most of our flexible ureteroscopes, endoscopes comes into this semi-critical category. Non-critical is the one, any instruments coming into contact with intact skin, like blood pressure curves, OT table, other things. Why this is important? Based on this classification, it can help us to devise what kind of decontamination is needed, whether sterilization or high-level disinfection or low-level disinfection is needed. So this classification is very important. It has some pitfalls. Sometimes it may oversimplify any complicated medical equipments. It doesn't say, so it's very difficult to choose which level of disinfection. It doesn't say an optimal contact time needed for high-level disinfection and other things. Few terminologies like cleaning is the first step in every decontamination process. This is just removing any visible dirt, debris, or organic matter from an equipment. It's just don't eliminate any microorganism, just remove any visible debris from the instrument. Disinfection, it destroys all the microorganisms, but not all bacterial spores. Sterilization is the highest form of disinfection, where it completely eliminates all microbial life, including bacterial spores. I just want to specifically emphasize about antiseptic versus disinfectants. Antiseptics, it is mainly used in living tissue, whereas disinfectants is usually used in inanimate objects. So I know some people are using betadine or povidone iodine in cleaning an instrument. Ideally, that is an antiseptic, which is not useful in cleaning or disinfecting any instruments. Little bit about log detection. This you can able to see in most of the bottles or anywhere they say log detection. It's a standardized way of measuring the efficacy of sterilizing and cleaning in liquids. This actually represents how much the microbial population is reduced by a factor of 1,000. For example, 3 log reduction means 99.9% reduction, which means 1 out of 1,000 bacteria will survive. So biofilm, this is very relevant with respect to this topic. So we are more, as a urologist, we are more worried about this biofilm. It's just a slimy communities of bacteria. Once they adhere to the instrument, they form a matrix. As a result, this bacteria gets embedded into the matrix. They are highly resistant to antibiotics and disinfectants. So sometimes if you leave it for a longer time, sometimes this may transmit to the other patients, and it may escape cultures. So this is the one which we are more worried rather than any other thing. So what are the steps involved after finishing the case before going to central sterile service department? There are 7 ways: point of care pre-cleaning, disassembly, leak testing if they are using flexible scopes, enzymatic soaking, and manual brushing or mechanical cleaning, then rinsing with RO water and drying. This is point of care cleaning and disassembly. This should go hand in hand. As soon as the procedure is over, the staff nurse who is in charge will disassemble all the instruments. Here in this resectoscope, outer sheath, inner sheath, resecting element, the loops, the cables, everything is disconnected. Ideally, we need to wipe away with a moist gauze to wipe away all the blood and tissue. This is a very, very important step. Otherwise, if it gets dry, then it gets easily formed biofilm. If there are any ratcheted or hinged instruments, they are kept in open positions so all surface can be reached. This is followed by manual cleaning, where we normally have a big basin. Inside the basin, we fill it up with a freshly prepared low foaming neutral pH detergent. And ideally, low foaming agent should be used because of 2 things. One, it allows complete cleaning of lumen. It doesn't interfere with our vision. Second, it will inhibit good fluid contact with device surfaces if there are excessive foaming. We need to wash all the debris as shown in the picture. We tend to wash from the distal to proximal. Every joints and every side channel should be washed. Then we need to brush all the endoscope channels. Then we need to flush with the same solution. Make sure any other dirt elements are there inside will be washed out. Then this is followed by soaking the endoscope in an enzymatic detergent.
हेलो जगनमन उससे बात हो सकेगी
And to the next step is we put all the washed scopes inside an enzymic solution with a neutral pH. We usually keep it for 10 minutes as recommended by the manufacturer. Little bit about what kind of solutions we use. There are a variety of solutions available in the market. Ideally, it should be neutral or near neutral pH because it is compatible with the material and it will good dirt removal will be useful. Enzymatic solutions are preferable because it contains protease, lipase, and amylase. Each has its own function. As soon as soap, it should be rinsed to avoid any disinfectants going into the patient or going into the sterile department. Alkaline-based cleaning agents should be avoided as they can be corrosive. Things which I use in my practice, I have highlighted. I have no conflict of interest. This is the one aseptic HC plus. It costs around 200 to 300. They say 3 log reduction in bacterial count. It is highly bactericidal, fungicidal, yeasticidal. It has chlorhexidine, cetrimide, and alcohol. Normally, I'll take 10 ml and dilute into 1 liter of water. I use this solution mainly for manual brushing and scrubbing of the instruments as shown before. This is followed by soaking in an enzyme cleaner. We use rapid multi-enzyme cleaner. It contains 4 enzymes highly active against proteins, carbohydrates, lipids, and mucopolysaccharides. Fast acting, stable, and a longer shelf life. It can be used for most instruments, and we use it for 10 minutes to soak it in the instrument. Regarding the dilution, we normally use 10 ml in 1 liter of water and we dilute it for a few minutes. Then we put the instrument for 10 minutes. There are a few centers, they are having wash disinfector and ultrasonic cleaner. Little bit brief about that one. Wash disinfector, it's actually like a commercial dishwasher where it cleans the instrument and disinfect everything. In ultrasonic cleaner, it produces a high frequency sound waves. This produces a cavitation bubble that disrupts the bond that hold the matter to the surfaces, thereby dislodging the debris. Ultrasonic cleaner is only a cleaner, it's not any disinfector. Once the manual scrubbing is followed by soaking is done, then the most important part is rinsing. We use RO water because tap water is heavily contaminated with so many organisms. As a urologist, we are more worried about pseudomonas because they adhere to the pipe walls. They survive and multiply just within 20 minutes and form a biofilm. So now to avoid that, we always need to use RO sterilized water. This is how we do rinsing. We always use a pad so that even if my staff nurse accidentally puts the instrument, then this will avoid damaging the instruments and scopes. And this is how we wash our flexible ureteroscope. And the bottom video is the one we have special gun attached to the pipe, and it comes with a little bit force so that we can able to wash away all the side channels and working channel to wash away all the disinfectants and detergents which was there in the scope. Then once we do the rinsing, then we need to inspect. At the minimum, all instruments we should individually inspected, and it should be visibly clean. Then this is followed by drying. Drying is very important because otherwise the damp environment allows the bacteria to regrow and form a biofilm. Avoid using high pressure as it can damage internal channel of the flexible endoscopes and also rigid scopes. Drying, we always use pressure regulated, filtered dry air and free of oil residues. Ideal pressure should be 15 to 30 psi, and guidelines recommend minimum of 10 minutes of air drying. This is what I have in my hospital. This is a blue wire which is connected to the compressed air. This is the one monitor which shows how much pressure we are using. This is the gun which we use to dry the instruments. So as soon as this is how we dry, we tend to keep it into 25 to 30 psi for drying the rigid instruments. For flexible ureteroscopes, I do usually use biorad. Company people doesn't recommend any drying. I usually keep it as low as 5 psi. So far, touch wood, there is no damage to any instruments. Usually, the company people recommend using a forced syringe drying, but I'm comfortable with this one. Automatic drying, this is available in some centers where once the scope gets rinsed, they are connected to the tubings, which is connected to the machine, which will dry it automatically. Once drying is done, there's if some scopes, if there are which the opening closing tap is very tight, then we tend to use a silicone lubricant so that it will be very useful. Even it will be used for any hinges or any scissors or any laparoscopic scissors where we use this for lubrication. Once rinsed, dried, then we put the instrument in a padded tray, and scope sleeves are used to avoid physical shock. We should not stack it one over the other to avoid damage to the instruments. Regarding the flexible scopes, we make sure that the tip is straight and it is coiled loosely to avoid permanent snap of the internal fiber bundles. And it is secured safely with the silicone or blue inserts. Otherwise, it will cause trapping injury to the shaft. Documentation is the most important thing. So whoever does, usually the nurse who is assisting is in charge for that particular case, should make sure that this goes to the CSD very safely. They should have a logbook where they write down the name and what was the instrument we use, and the time the procedure was started, the pre-cleaning was initiated, the leak testing was done, then what was the detergent used, and when was the rinsing and drying done, and they need to sign and they need to maintain a logbook. Some centers are using instrument tracking software to scan the barcodes, and they generate an electronic strip so that it will be useful to track it electronically. Regarding the quality control, any system should have a quality control, otherwise the whole thing will fail. There is no real-time test exists in a clinical setting. As a minimum, we should recommend biological surveillance every 3 months. Endoscopes and the water used in endoscopy, we use RO water should be tested at the same time. Regarding this, so endoscope channel, we take a 20 ml syringe in the sterile saline, we flush it, we collect it in a container and send it to microbiology. And also water sample, we take 2 water samples and in a sterile syringe, put it in a sterile container, and they send it to microbiology for incubation to look for any growth of organisms. Once it goes to CSD, then we need high-level disinfection or autoclave or ETO. I think the speaker will be going to go to that one. So where are all the failures can occur? It can occur from the starting point, from failure to clean instruments, or if you don't do correct disassembly, or if you don't do manual cleaning, or if the recent cleaning solutions are not good, or if you don't do insufficient rinsing, then all these are the failure points in cleaning surgical instruments. the most important thing is adequate staff training. I know people keep coming and the junior nurses will be coming and junior colleagues will be operating. And whatever it is a nurse in charge. He is the one who needs to supervise initially before going into individual in charge for sterilization. Other things like overloading of ultrasonic cleaners, improper cycle selection, all these also act as a factor for failure. The last one is equipment malfunction. If you don't identify it at the correct point, then it may lead to surgical backlogs. So then it will then we need to make sure everything goes in well. So key takeaways, everything is a distinct process: cleaning, disinfection, sterilization. Among this, the most important time-sensitive step is point-of-use cleaning. That is the time where biofilm forms, and it is a multi-step sequence. And the most important thing is all are preventable. Thank you.
Thank you. Thank you, Dr. Kritik. That was an excellent talk. Almost all the practical points you have covered. So I will move on to the next topic. I will now invite Dr. Kawaljit Kaura from AIMS Batinda. So he will be talking on high-level disinfection in urology, principles, practice, and pitfalls. We'll have all the question and answers at the end of all the 4 talks. Over to you, Dr. Kawaljit, sir.
Good evening, Dr. Karthikeyan. Hopefully I'm audible to all.
Yes, sir. Audible, visible.
First of all, I thank you and ISU Urology to give me this opportunity to present this talk. And since I have listened to the slides of previous speaker, this topic is, I feel like many of the slides might superimpose. So I will try to skip the slides which might superimpose. Let me share my slides, please. Just a second, sir. It's taking some time.
You can keep the PowerPoint open and then start the share screen option. Then you go back to the previous screen.
I'm trying, just a minute. Actually, there was some internet issue. I had to use at the last minute my other computer. Just a second. PPT. Should it? Background. Something wrong with screens. Microsoft PowerPoint. Sir, I think I'm having some issue. Give me.
Oh, can we move ahead with the next speaker?
By the time you go with the next speaker, I will join with the slide sharing.
Yeah, Dr. Balagopal, sir. Dr. Balagopal, sir, are you ready?
Yeah. Just let me see. I'm sharing my screen. Is it visible?
It's getting open. Let's see. Yeah, fine. First class. So now I invite Dr. Balagopal Nair to give his talk on sterilization of urological instruments, getting it right every time. So this time also you got it right.
So at the outset, I would like to thank ISU, USI, and Karthikeyan for considering me for this job. So without much ado, as everybody else, and without wasting much time, I'll straight away go ahead with the topic that has been allotted. And as Kawaljit said, I will skip some of the slides which are common and sharing. So basically, Karthikeyan had told me, given a clear-cut guideline on what to focus on. And my topic has been like sterilization of urological instrument, getting it right every time, with focus on steam sterilization, plasma ETO, the packaging and storage, and the use of biological and chemical indicators, and with instrument compatibility. So this definition, I think Kritik had already talked about it. So to get it right every time, you need to know the delivery of the sterile instruments depends on the effectiveness of the sterilization process, the design of the unit, the decontamination, disassembling and packaging, loading the sterilizer, monitoring the sterilant quality and quantity, and appropriateness of the cycle. Cleaning has already been dealt. So I'll straight away go with the sterilization process. And sterilization, that is the steam sterilization, involves the use of moist heat as a saturated steam under pressure. It is non-toxic, inexpensive, and rapidly microbicidal, sporicidal, fungicidal. The heat penetrates the fabrics, and the mode of action is by destroying the microorganism by an irreversible coagulation or denaturation of the enzymes. It's used in all critical and semi-critical items that are heat and moisture resistant. So, oh shit. Let's do it. So the basic principle, as I mentioned, is to expose each item to direct steam and contact at the required temperature and pressure over a specified time. And there are 4 parameters that are important. One is the steam, which involves the dry saturated steam entertained at a dryness fraction of 97%, with a temperature with a high pressure, which is required to obtain high temperature for quickly killing the organisms. The temperatures range from 121 to 132 degrees centigrade. These are the 2 temperatures at which it is used. And over a period of time, the 121 degrees centigrade temperature is used over 30 minutes, and the 132 degrees centigrade temperature for 4 minutes. And it also depends upon the type of the item, whether it's wrapped or unwrapped, and type of sterilizer. So there are 2 types of sterilizer. One is the gravity displacement autoclave system, where there is displacement with the vacuum. It goes down. The steam comes from above or the sides, and then it goes down. Or there is the high-speed pre-vacuum sterilization, in which there is instantaneous steam penetration and it takes less time. Here I would like to mention about the flash steam sterilization, which was originally described by Underwood and Perkins for sterilization of unwrapped, quickly sterilizing the unwrapped objects at a temperature of 132 degrees centigrade for 3 minutes, applying the pressure of 27 to 28 pounds in a gravity displacement sterilizer. An open tray or specialized designed covered containers can be used. But this has got some adverse events can happen. One is burns to the staff or the patient who handle that. Second is infection. Because these sterile items are become open to air, and it will eventually become contaminated. So the longer a sterile item is exposed to air, the greater number of microorganisms that will settle onto it. It can be used for processing the clean patient care items that cannot be packaged or they cannot be stored before use, or you have an insufficient time to sterilize an item by the preferred package method. It should never be used for the reasons of convenience. There have been some ways in which you can improve upon the flash steam sterilization, and one is by keeping the equipment close to the proximity to the operating room to facilitate delivery to the point of use. Extended exposure time, that is, instead of 3 minutes, make it 4 minutes. Use biological indicators that provide results within an hour, and also protective packaging. And the company also has come with the rigid reusable sterilization containers to improve upon the sterilization effectiveness and safety. The advantages has already been mentioned: non-toxic, inexpensive, rapidly microbicidal and sporicidal. And the disadvantage is corrosion and combustion of lubricants associated with some of the instruments. Now we'll go ahead with the low temperature. This was the high temperature sterilization. The low temperature sterilization process, which is now more in vogue, the other one is also there, is ETO, the gas or the plasma, and vaporized hydrogen peroxide or peracetic acid. So ETO or ethylene oxide is supposed to be one of the most commonly used world over. In spite of some controversies with it, still it is one of the most commonly used. It's a colorless gas with sweet odor and is flammable and explosive. There are 4 essential parameters for the effectiveness of ETO sterilization. These are the gas concentration, the temperature at which is to be done, the relative humidity, and the exposure time, which ranges from 1 to 6 hours. So world over, approximately the US statistics says that about 50% of all sterile medical devices, including over 20 billion items, rely on this process. And way back in October 2019, the FDA warned that without the availability of ETO as a sterilization method, there will be a shortage of essential life-saving critical devices like drug-eluting cardiac stents, feeding tubes, catheters, etc. So the key advantages of ethylene oxide sterilization. Whether the ETO can, it is still, it's an important part of the sterilization tool that you have. One, it is a low temperature sterilization method, uses 37 to 60 degrees centigrade, which prevents heat damage to heat sensitive plastics, polymers, electronics. There is deep penetration into complex and closed spaces, particularly the scopes, and reaching inside lumens, joints, hinges, and multi-layer packaging. Even they are all pre-packed. They go into the ETO sterilizer pre-packed, and this is safe for delicate optical instruments like sensors, cameras, and scopes. And it is material compatibility. It has material compatibility with approximately 95% of the medical devices without causing corrosion or deformation. The key advantages: sterilizes without unpacking. It is effective against all sorts of microorganisms, including fungi, viruses, and spores, and is ideal for rare and fragile materials. And it's been out of context to our thing. It has been used for preserving the fragile artifacts like ancient manuscripts or delicate textiles and all. So ETO evolved when few alternatives existed for sterilizing heat and moisture sensitive medical devices. The disadvantages: it's flammable. It has got lengthy cycle and aeration time. It can take about up to 6 hours. And then the environmental toxicity, the toxic residues being fluorocarbons. And in turn, there is the healthcare worker safety involved with it. So I will come to it that there have been now the newer versions or some advancement in ETO has been able to tide over this. The mechanism of action, it's through a process called alkylation, disrupting the DNA, protein microbes, and rendering them, the replication or reproduction is stopped. And it penetrates the porous material and hard to reach areas, particularly the scopes, with the lumen, and where there are hinges and all. The sterilization process involves first the pre-cleaning, like all sterilization, then packaging them in special sterilization pouches or wraps, and then loading them. There is a systematic loading into the sterilizer. Once it is loaded, the sterilization involves first the vacuum removes all the air, then there is this addition of the moisture, and then introduction of the ethylene oxide gas, which comes in a canister. So because of this preparation, I went for the CSSD for the first time, and then I was able to see what it is. Usually, we urologists, I believe, are not much. I was not much aware of all the processes, but yes, it has helped. So there is then the next phase is the aeration phase after the sterilization by the introduction of the gas, in which the removal of the residual involves removal of the residual ethylene oxide. And there are different ways of doing it, by either nitrogen washes, which dilutes the gas, then added heat, which accelerates the degassing, and extended aeration time in heated cells lasting from 6 to 24 hours. So this ensures the safety and usability of the sterilized item. As mentioned previously, 3 factors determine the effectiveness: temperature, humidity, and gas concentration. And finally, the exposure time. It requires sufficient time to penetrate materials and interact with microorganisms. Therefore, the ETO sterilization is time consuming. That is one of the disadvantages of ETO sterilization. And So the ETO, it inactivates all microorganisms, all the bacterial spores, especially, are more resistant. But one of those, even the more resistant spores, that is Bacillus atrophaeus, is also sterilized, and it is used as a biological indicator in case of ETO sterilization. There have been, as I mentioned previously, the advancements. There have been automated controls for simplifying operation and reducing human errors, enhanced safety protocols in implementing the advanced leak detection and other containment systems, data logging for recording the sterilization cycle for quality assurance and compliance, and energy efficiency, reducing the operation cost. 2 ETO gas mixtures which are used because of the hydrofluorocarbons, which reduce the toxicity. One is with CO2 mixture or with 100% oxygen. The ETO has got toxicity. It can cause eye pain, sore throat, difficulty in breathing, or blurred vision. It can cause dizziness, nausea, headache, convulsions, bitterness, and vomiting. Karthikeyan, you can tell me when I'm overshooting my time. Huh?
Sure, sir.
Okay, I'll just cut that time. It is linked to spontaneous abortion, genetic damage, nerve damage. Tissue burns to patients have been reported with ETO residue. And this residual ETO in capillary flow dialysis membrane has been reported to cause neurotoxicity. These are some of those regulatory
three
standards.
more, sorry to interrupt, sir. 3 more minutes.
Okay, so I will go ahead with the gas plasma, which was patented. It's the fourth state of plasma, and it's generated in an enclosed chamber with deep vacuum using radio frequency or microwave energy to excite the gas molecules and produce charged particle. The mechanism of action is by free radical and interact with essential cell components and thereby disrupt the metabolism of microorganisms. So these are, it's basically a busy slide, but to cut short, the operating temperature is about 37 to 44 degrees centigrade, and the cycle time is about 75 minutes. And the newer versions, in which 2 cycles of hydrogen peroxide is used, has come down the time to 73 to 52 minutes, and the newest version has come down on the time to 28 to 38 minutes. Here again, Bacillus atrophaeus is used as the biological indicator. So the mode of action, it's generation of hydrogen peroxide and generation of free radicals during the plasma phase of the cycle. Then I'd like to mention something about the physical facilities that are required in these. I've been interested with about storage and packaging also, the topic. So it involves decontamination, packaging, sterilization, storage. And the storage area should have barriers, should separate the decontamination area. And there should be reusable contaminated supplies are received, sorted, and decontaminated in these areas. They have specific criteria about the air exchanges which is required. That is 6 air exchanges per hour in the decontamination area, and in the sterilizer area, it should be around 10 air exchanges. This is how it should be arranged. Packaging area is for inspecting and assembling and packaging these. So it should be a limited access area with a controlled temperature and a humidity. The floors and walls materials capable of withstanding chemical agents, and there should be space between the floor and the roof. There should be so that there is no moisture in contact with these when you store these instruments. So for packaging, those instruments requiring sterilization must be wrapped or placed in rigid containers. Hinged instruments should be open. Items with removable parts should be disassembled, and unless the device manufacturer or researcher has provided some specific instruction. So there are several choices of packaging material: peel open pouches, rolled stock or reels, sterilization wraps. And also they have particular material characteristics also, which allows penetration of the sterilant and provides protection against contact contamination during handling. So these are some of the ideal sterilization material. The ideal sterilization material should have these following qualities. And the packaging, you can have either double wrapping, which can be sequential or non-sequential. That is sequential, use 2 sheets of wrapper separately. In the non-sequential, they are simultaneous wrapping using 2 sheets, and reduces the time. And storage, the wrapped surgical trays remain sterile for varying periods depending on the type of material used to wrap the trays. Time
Please
for
conclude,
sterile
sir.
pack. Yeah. So this is one thing, no? The heat sealed plastic peel down patches and wrap pack sealed polyethylene overwrap sterile remain sterile for as long as 9 months. And the dating of the sterile pack, it's either time related or event related. Event related means if there is any tear in the packaging or the package becomes wet, then it becomes unsterile. So contamination of a sterile item is event related and the probability of contamination increases with increased handling. So there are monitoring. We use different chemical indicators. You have the biological indicators, as I mentioned previously. So to conclude, when properly used, disinfection and sterilization can ensure the safe use of invasive and non-invasive medical devices. Sterilization of all patient care items is not necessary in resource-constrained situation. And healthcare policies must identify primarily on the basis of items intended to use, whether cleaning, disinfection, or sterilization is again. This photograph is my scope, the flexible cystoscope, which has got damaged after sterilization. And we'll get on with that, the discussion during the discussion, what happened. Thank you.
Thank you, sir. That was a very comprehensive presentation on sterilization. So, Dr. Kawaljeet, sir, are you ready with your presentation?
Yes, sir. Yes, sir. I'm ready. I'm sharing my slide, please.
Yeah, I request the next two speakers to adhere to time. We are a little short of time.
So
Over
my
to you,
slides.
sir. Yeah, visible, sir.
Okay. Let me quickly start. Sorry for the interruption. Uh, I already said there might be some superimpositions, and I would quickly skip those and try to focus on the important aspects. We all know, we have discussed the basics, that Spalding classification forms the basis of this disinfection and sterilization based on what are the devices available. And this was a very beautiful study that I came across from a Journal of Infection Prevention and Practice, which clearly depicted that incidence of UTI after flexible cystoscopy ranged from 2 to 21%, and organisms we all know, E. coli, Enterococci, and staph and Pseudomonas is responsible for 2 to 5% and is emerging. Spalding classification, I will not go into the detail, only focuses semi-critical devices. Semi-critical devices is the category in which most of the urological equipments they fall, and that is where lies the role of high-level disinfection, and that is currently I'm going to focus today. And quickly going to the basic difference between the high level and the other level of disinfection, that it kills more than 99% of the microorganisms, and some of the larger spores are left that cannot be disinfected with the high level disinfection, and that requires what we call in high level disinfection and sterilization. The sterilization eradicate all the endospores. This is a very interesting slide that I got while I was going through here. This is one of the pitfall of this Spalding classification. The diseases like Creutzfeldt-Jakob disease by the prions, they actually are not amenable to any level of disinfection or sterilization. And as we go from the spectrum of prions to the HIV, HCV, HB, S antigen, we see that the organisms, they are more susceptible to the disinfectants. This is a very good example that I got. I thought I'll be sharing that the difference between low level HLD and sterilization is like this is given in CDC guidelines, and it is very, very simple to understand. Like HLD is like washing a plate, thoroughly washing a plate when it has used in food, and sterilization is like cleaning a baby's bottle. So with this background, I will directly go for high level disinfection. High level disinfection I will categorize into two for the discussion. One is manual, and the other one is automated, that is in use these days. The chemical agents most commonly used, I'll be discussing the most common ones in practice. They are glutaraldehyde, OPA, paracetic acid, and hydrogen peroxide. I'll be discussing about them in the due course of slides. Just this workflow solution, this is the one that initially gives us an idea of high level disinfection, how it proceeds. As my previous speakers are already told, how the scopes, they go from the use to the CSSD, where the manual cleaning is of utmost importance, followed by the adequate level of exposure at adequate level of temperature to the high level disinfection chemicals, followed by drying and storage, and ultimately ready for reusing. These are basically the 8 essential links which are there in the decontamination chains. I will quickly narrate this, and in the sequential slides, I have given a brief description of this. As we have already discussed, the first is pre-cleaning, which is very, very important. Already previous speaker has gone through. I will just go with a few lines, followed by a leak testing. Leak test is very important for the flexible scopes, and the scopes which fail the leak test, they should directly move to the service, and they are not to be used. This is further followed by manual cleaning, followed by rinsing with the enzymatic solutions, and which is followed by the high-level disinfection, exposure to the high-level disinfectant for an adequate period of time under adequate temperature that is given by the manufacturer, which is then followed by the final rinse with the sterile water, ultimately followed by drying, and ultimately storing them in a vertical manner in a specialized the slabs that are available. The point to focus here is that each step is a critical link, and any failure in any step will compromise the entire process, and documentation, as previously told, is very, very important at each one. With the important step, pre-cleaning already described, it is a very, very important aspect, and it starts with certain enzymatic solutions like Enzol, Enzyme, Prolysitica, Verozyme. Already previous speaker has gone through this. And immediately after use, we wipe down and flush the lumens with these solutions, and remove the organic matter. And if heavily soaked, we soak them for the longer time. This is followed by leak testing, already have described, and rinsing thoroughly to remove the detergent. The next step is immersing into the solution, and that is, we need to completely submerge the scope into the high level disinfectant solution, and 20 to 30 minutes. And I will in the next few slides, I will describe the different the parameters that have been given for the different solutions that are currently available with us. We have to ensure that there's a proper exposure of the scopes or the instruments to the chemical. Make sure all surfaces, lumens, and channels are filled and exposed to the solution, and adequately and strictly adhere to the time duration as given by the manufacturer company. Then followed by post disinfection rinsing with the sterile or boiled water, filtered water to remove the chemical residue. This is need to be followed by drying. Drying thoroughly require a sterile cloth or air dry cover, or we have just gone we can completely dry it, and followed by the storage. Store vertically in a clean designated area, often with the protective covers. This is just diagrammatic presentation, but I have already told. The primary goal of pre-cleaning is to remove the blood and the debris. Leak testing, and this is the manual cleaning with the brushes. More than 90% of load is usually removed. This is just a description. In the next slides, I will describe in detail about the commonly available HLD agents that are there with us. Again, just for the description, we have glyceraldehyde, we have glutaraldehyde OPA, and then we have hydrogen peroxide and peracetic acid. This is how we need to dry. We need to properly dry all the internal channels and external surfaces of the scopes with the compressed air. The pressures already are fixed. There are fixed criteria under which we should dry, because we all know that wet scopes will create a breeding ground for bacteria, and obviously biofilm will form, and biofilm is a very important cause of HLD failure. We need to hang them in a vertical manner and avoid contacting with the floor or the walls, and adequate coiling prevent the coiling. now closer to the person who is handling them. And this is what has given way to the automated HLDs. Concerns is regarding the skin irritation and the allergic reactions, regarding some asthmatic reactions that has been reported to the workers, and that is why it is recommended that the person who is handling the scopes with the HLD, the chemicals, they should use proper PPE, gloves, masks, shields, and it should be done in a properly ventilated area so that exposure is limited, and documentation of all these steps is the norm. Now, let us quickly learn about the most commonly used agents. I have described the 4 most commonly used agents. First is Sidex, we all know, glutaraldehyde. Second is OPA. Third is parasitic, and then hydrogen peroxide. Glutaraldehyde is 2.4 to 2.5% solution. In the market, it is available at the name of Sidex. It is the oldest used and the gold standard HLD chemical, and it is usually available in a inactive form and require mixing and activation before it is used, and it is reusable up to the 14 days, and distinct pungent odor requires a well ventilated and areas where we need to activate it, and the common contact time for this agent is 20 minutes at 20 degree Celsius. The ingredients or the components of this Sidex, they are the glutaraldehyde, water, buffer like potassium phosphate, and corrosion inhibitor like benzotriazole. Mixing with an activator, soda bicarb, is the norm. It is required to activate this solution. Now, Sidex OPA, just a second. The mechanism of action of Sidex, it relies on the alkylation, where the reactive aldehyde groups, they cross link and bind to the proteins, enzymes, and nucleic acids in the outer cell wall, and then this irreversibly leads to the cell death. Advantage of Sidex is that it is inexpensive. Sorry. The average cost that we 900 for 5 liter. It is the longest used chemical we have, and it is broad spectrum antimicrobial properties. The disadvantages are strong fumes. It causes skin irritation. It causes eye irritation. Asthma reactions are there, and it require adequate ventilated areas. Now, the second most commonly used is orthophthaldehyde, OPA. It is called Sidex OPA. The trade names usually available are Sidex, Hospidex, or Solvenza. The concentration is 0.55%, and immersion time is 12 minutes at 20 degrees Celsius. The advantages of this Sidex OPA compared to the traditional Sidex is that it does not require any activation. It is ready to use. No activation is required. The odor is minimal. It is less irritating than the Sidex. Excellent material compatibility is there. The mechanism of action is same. The disadvantage is the cost. It is more costly. Here in Punjab, it costs around 2,500 per 5 liter. It can stain the skin and clothings, and it is not suitable for patients with known hypersensitivity. Now, third one is parasitic acid, different trade names. It is available at Rapicide, Microquel. The mechanism of action is denaturation of proteins, again the disruption of cell wall permeability, and the oxidizes the sulfide and sulfur bonds in proteins, enzymes, and the metabolites. The advantages are it lacks harmful decomposition products like acetic acid, water, oxygen, and hydrogen peroxide. It is rapidly sporicidal and effective against Sidex resistant mycobacteria also. It produces environmentally friendly byproducts and leave no residue. The sterilization cycle time is rapid, 30 to 45 minutes, and it is compatible with many instruments. The disadvantages are it can corrode the copper, brass, bronze, plain steel, and iron, and it is considered unstable when, particularly when diluted. And the cost is more per kg. It's cost around 1,000 to 2,000 per kg, and again it can cause some serious eye and the skin reactions.
Sorry to interrupt, sir. 1 more minute to conclude.
I'll just go through. Now, certain factors are there which affect the high-level disinfection. This is the number and location of microorganisms, resistance, concentration, and potency. organic matter exposure, and biofilm. Biofilm is very important cause of HLD failure because the chemicals cannot penetrate the mature biofilm. Hence, adequate drying of the scopes is required. Now, automated HLD has taken the place of the manual because of the time-consuming manual process, complex process, and exposure of the manpower to the chemicals. So that is the reason, and the advantage of automated machines are that they disinfect the medical devices very quickly and eliminating the human error and improving the patient safety. This is the same. This is some of the examples that I'm showing about the automated endoscopes that are available. The cost is very high, 28 lakh, 255 lakhs and all. Now, already sterilization assurance level already been described by the previous speaker regarding the logs available. I will not go into detail. Quickly, I will go to the take-home message. Take-home message is actually in the form of a very important journal, International Journal of Urology, that has given certain guidelines in 2021. They are based on Spalding guidelines, and clearly it says that endoscope should be cleaned immediately after use and disinfected or sterilized to avoid patient-to-patient or patient-to-operator infection. Second most important point is to follow the specific operating instructions in the manual available for different scopes. And we know glutaraldehyde and paracetic acid are highly potent disinfectants we have available with us. And the last slide with which I would like to conclude is that the 4 pillars of high-level disinfections, they are: number one, pre-cleaning, because the ultimate success of the entire process is going to be determined by the quality of initial pre-cleaning. Second is strict adherence to the contact time. We need to respect the contact time as per the manufacturer instructions. And third is post-contact dryness, because proper drying and storage prevents the biofilm formation. And if biofilm forms, it is a failure to high-level disinfection and ultimately documentation. So I think all of our urologists, all of us should be actively involved in this sterilization process. As sir said, that we are not very familiar with whatever is happening. Even in a setup like AIMS, we have a very set standard. People are there who are taking care of these equipments. But when I was preparing the slides, I went through the details, and this has actually given some of the things which has opened the eyes. And personally, I feel like for both the private and for the government sector, we should personally guide our staff who is dealing with the disinfection and sterilization. And I think concerning and considering these factors, we can ultimately result in less of contact infection with respect to the scopes, and ultimately the result is the patient safety. Thank you so much.
Thank you, sir. That's a very lucid talk, very informative one. So now I will invite Dr. Abhishek Singh to talk about the future of urological sterilization. Over to you, Dr. Abhishek.
Thank you, Dr. Karthikeyan, for this wonderful opportunity. Respected President, Urological Society of India, Secretary, Urological Society of India, Chair, ISU, and my colleague and Chair of the webinar, Dr. Karthikeyan. I've been assigned the duty of talking on future of urological sterilization. With respect to single-use technology, where are we headed in terms of automation and what the future looks like? So my disclosures are that there's no central resource for gathering this information. All the information presented is gathered by personal inquiry. The presentation also reflects some personal biases. AI was used to generate some images and videos in this presentation. Dr. Kawaljeet just told us the importance and the cycle of sterilization. The hinge pin of a good sterilization is standardization. Can I do it as good as you do it, and can I do it as consistently as you do it? That is the most moot question that I'm going to try to answer in the future of sterilization. Why sterilization is no longer a backroom issue? Because we all, generally speaking, are very, very high volume procedure centers. If with respect to at least stone procedures, where the moot of sterilization at this point is flexible ureteroscopy. So that is probably the most common stone procedure done worldwide. The instruments are fragile, complex, delicate channels are there. And if you don't sterilize them well, there's a possibility that there'll be a lot of patient harm. Now we are being watched. What has become different is that we are being watched. There are regulatory issues, there are medico-legal issues, and lastly, there are some environmental implication of whatever we are doing. So disposable ureteroscopes, are they good enough? Yes, clearly there is enough data to suggest that they are as good as a reusable ureteroscope, and miniaturization is the next frontier where we are almost headed there. But the point is, what is different is that disposable ureteroscopes are being reused. And what is the sterilization standard for disposable ureteroscope which are being reused, or we can now call them limited use ureteroscope. So this is a data from India and the subcontinent where 2000 odd patients were studied, and about the times the ureteroscopes were used were in 88% of the patients it was about 2 times, and in some of them it was 3 to 5 times. But we know that the real world data will tell you that scopes are used more often than not. So what is the way in which you can standardize sterilization of these equipment is extremely important to understand. As our volumes are increasing, one middle path regime is that you use reusable for some and disposable for some. Or if you want to talk this through in terms of sterilization, you really do high level disinfection for for the routine cases, and use sterilization for some of the complex cases, complex anatomy, previously infected system, and where you are going to work for a long time. So that is how you could create a middle path. What is the problem with reprocessing, especially manual reprocessing? If you look at these instruments, they will always contain some kind of a protein residue. If you try to find out hemoglobin traces, about 63% of the patients of the models will have some kind of hemoglobin that will be detectable. ATP will be elevated, and they will microbial growth will be positive, will be seen in about 10 to 15% of them. So these are the problems with manual reprocessing. Therefore came the concept of automated reprocessors. Reprocessors, the idea is that it will democratize whatever are doing, that my reprocessing and my sterilization or disinfection process will be as good as yours. So it will follow the same cycle, but it will be done in an automated manner. So this Pantex actually came up with a device like this. This is known as the Aqua Typhoon. Once the instrument is just dried and rinsed, so a part of pre-cleaning is done. Then there are different color-coded channels that are attached to different channels of the scope. This was classically described for the duodenoscope, now can be extrapolated to the flexible ureteroscopes. You connect them to the channels, give them their gestational time, and within a period of 3 to 5 minutes, pre-cleaning can be done. And some channels will then inject the fluid, which will be a disinfectant through the channels. Again, wash the channels. Channels will be dried. It can be kept in the dedicated bags, and these bags where they can be done, plasma sterilization can be done, and then they can be stored for about a month. So this is how automated processing can be done. Now, is it just an option, or it may become a regulatory issue as we go along? Because FDA and CDC has given framework in accordance to which things should be done, it will slowly start to pass on towards the east, and there is a high possibility that the compliance, the regulatory compliance will keep on increasing in terms of the standardization. And when you use such automated processes, the standardization is easier to achieve. Can they be integrated with the digital ecosystem? Yes, they can be. Olympus offers an intelligent endoscopic ecosystem. So it basically it is a cloud connected AI model which helps you maintain the entire log, how the instrument came in, how it was sterilized, how is it stored, and when was it reused. So this kind of chain is available. Now, coming to the next aspect is RFID tagging of the instrument. So you put instruments are tagged with a small RFID tagger, and each of these tag can sustain about 1,000 sterilization cycles. A tray containing about 60 to 80 items can have different RFIDs, and at a throw of a button, you can know what are the types of instruments that are there, and and you can digitally record all of this, and then you can track their journey. So basically, this is how a RFID tracking tool works. So you put, these are all RFID tagged instruments, and at a go of a scanner, these are the RFID tags, which I told you can last about 1,000 cycles of sterilization. And each tray can have about 60 to 80 items. So at a push of a button, you'll know how many items are there, how many times have they been reprocessed, what is the position of the instrument in the cycle, when you tag this to a particular cycle, did the cycle go through? So when this was used, they thought in a Copenhagen case study, about 31,000 man hours were saved per year. And this was out of a unit which had about 75,000 surgeries per year. So each tag lasted for 18 months and 1,000 sterilization cycles. So this can overcome many issues. One is instrument count pre and post operatively can be easily done. Then but the sterilization cycle can be tracked. If there is a break in sterilization somewhere, or if you get a post operative complication, you can track this particular instrument. So the end-to-end instrument life cycle can be visible. The entire trail of the instrument can be visible if you digitally track it. So that means you don't have to do audits. The audits are always ready. So the data can be linked to outcomes. Traceability data is starting to intersect with the clinical outcomes. When the instrument wears down, does it actually lead to increase in the complication rate in terms of infection? Does the cycle count predict the scope failure? So the data like this will be available by tracking this instrument, by tracking these instruments. And as I told you, the audits are always ready, so you don't have to really track the instrument, do the manual audits or maintain the manual logs. Now, there are situations where we use the third-party vendor loaner trays for specific procedures. Like either you have to send an instrument out for autoclaving, you don't have that sterilization, you don't have that particular device, or you don't have that particular tray. So there are certain instruments which require specific trays. So whenever their instrument goes in and out, the manual record keeping makes it very, very difficult to track this instrument. So the digital solution is purpose-built modules automate vendor communication and track the loaner asset in real time. They flag the item when it has not cleared the sterilization before the case begins. So this can help you get around the problems of the loaner tray. Now, what about the use of AI into sterile processing department? So there are a few areas of vulnerabilities. One is error in inspection during when you are trying to pre-clean the instrument, assembly and sterilization equipment failure. This can be identified by AI. Assembly verification, the computer systems can help you confirm if correct instrument assembly and complete tray composition was used. And there can be, you can actually using the AI algorithms actually measure what is the incidence of benefit, or what is the incidence of infection now after once you started using these particular cycles. The automated visual inspection of instruments remains experimental, but at present, like in other situations like reading the slides, reading the MRIs, it can support human judgment at least. Now, one good thing that AI-driven algorithms can tell you is that it can help you predict that this instrument is going to fail. Rather than being reactive, what happens is instrument fails, sterilization test in the real time, then there are case cancellations or delays. But if you can predict this before time, that say there are if you have bore scopes, that predict that the biofilm, there has been continuous biofilm formation in this particular scope, then the scope, the inner surface of the scope is damaged, then the scope needs to be discarded, and this has to be predictive rather than reactive. Now, AI algorithms can also help you inspect the scopes, inspect the surfaces of the instruments. So how this actually happens in real time is like in surgical milieu. This is a simplistic analogy. The algorithms are taught to identify instruments. So these are the instruments. They are annotated over and over. And then when they are jumbled, the algorithm will try to identify them. So this is how the sterile, unsterile instruments, the instruments with some kind of color codes, their distinct patterns will be identified by AI algorithms, and the AI algorithms will be able to differentiate between the sterilized and unsterilized scopes. This may be done based on the color codes. This may be done based on only the simplistic view. So depending upon what algorithm is being used, AI can help us go further. Last segment of my talk is about the environmental safety. The single-use ureteroscopes are said to be better in terms of the environmental friendly nature, because the amount of carbon dioxide produced by a single ureteroscope, which is disposable, is about 4.43 versus 4.47. Though the plastic waste that is generated by a single-use ureteroscope is far more. This is another study which showed that the reusable ureteroscopes cause far more environmental damage as compared to a single-use ureteroscope. Though these studies, though these studies have been done in different subsets, different milieus, so we all have to take them with a pinch of salt. But generally speaking, the single-use ureteroscopes produce more plastic waste, and reprocessing of the ureteroscope causes more carbon dioxide generation. So what is the future? The future is a hybrid future. Wherever you think that the problem is going to be severe in terms of complexity of the case, you have to use the single-use scope. The reusable and the automated processing units are more helpful when you're dealing with high volume of routine work. RFID traceability helps you to track the instrument throughout its course of sterilization, and then all the break-in sterilization will be identified. Plus, it will give you some additional benefit of counting the instruments in open surgery, keeping an audit of instruments, variability of instruments, and predicting if the instrument has come to end of life. So AI quality assurance, the emerging layer that standardizes what humans cannot reliably standardize alone. So what our departments must know, they must know our volume. They should audit our reprocessing pathway manually as well as by using the AI algorithms. We should invest in traceability. RFID barcodes are something that are not very, very costly. We can all look into it. And we should, when we are doing this, we should always look at sustainability. That means, are we really doing what helps the environment in the long term? And engage with your sterilization department. The sterile processing department is a clinical safety net and a strategic asset. They are no more a backroom function. On that note, thank you for a patient listening. Thank you for the opportunity.
Thank you so much, Dr. Abhishek. That's a real eye-opening talk. Many things are new to most people. A lot of things we have learned. So now we move on to the most awaited session of question and answers. I'll be throwing quick questions to all the panelists one by one. I'll be calling by the names. I request ISU Chairman, USA President and Secretary, and Rakul Gupta sirs to add points wherever necessary to make the discussion more valid. I request the panelists to keep the answers quick and short in 1 or 2 lines. The first question to Dr. Kritik sir. What is the minimum sterilization and disinfection infrastructure required for a standalone urology center? I own a urology single standalone center. What should I need? You are not audible, sir.
Kritik, you are muted. Unmute.
So you have to unmute yourself, sir. Okay. Balagopal sir, can you take that question? What is the minimum sterilization and disinfection infrastructure required for a standalone urology center?
For a standalone urology center, probably you need to have the high level disinfection, considering the parasitic acid or the perfectant that has come. One. Second, probably invest into a plasma sterilizer. These are because now the instruments that we are using, they have now see the instruments that we are all using, the cost of those instruments is high. So I think easily now we can afford those standalone can afford a plasma sterilizer. That's what my take on it is.
Thank you, sir. I will add steam autoclave also, and also to train the staff nurses adequately on sterilization process. So autoclave and high-level disinfection and the staff. So Kawaljeet sir, how long can an instrument remain sterile after processing if it is not used?
I feel like it all depends upon the how well the time duration is documented, how well the record of this equipment that has been sterilized is maintained in the hospital, and if properly, like how the instruments are stored properly, like I said, vertically stored in a covered cabinet. So if everything is done in a proper SOP specific manner, so then I feel like the duration can be yeah, say up to 2 weeks or a month or so. And
So if autoclave is done, how long we can keep? If ETO is done, how long you can keep? If everything is kept well.
I feel like there is no number that I can say, but I think we can use it. In a month or
Okay.
so. Yeah.
Can I take that?
Okay.
Can I take that?
Yes, sir. Yes, sir.
So, see, basically, it depends upon the sterilization method that you have used, the wrapping or the packaging that is used. Now, if you have used a peel packing that is there, the double layer packing and an ETO sterilizer and an ETO sterilization, they can be easily kept up to 9 months.
Okay.
That is what the CDC guidelines says, that if there is no breakage in that sterilization thing, you can keep up to 9 months.
Got it, sir. Keshav, sir?
I think, Karthi, did somebody touch upon gamma sterilization?
No, sir.
No.
Because in the bulk, no, that form of sterilization is what helps. In big institutes, it is certainly a very good form of, you can save cost.
Oh, okay, sir. Okay, sir. Got it, sir. So, Dr. Kritik, sir, can you take this? Sidex versus Parasite. I am a single-centered urologist. I have an average of around 3 to 4 cases in a day. What should I use, Sidex or Parasite?
I would prefer Sidex because it's low cost and probably it's a low volume center. 20 minutes is easy to turn around rather than high volume center, and it can last up to 14 days. So I would prefer rather than Parasite. Parasite is more useful probably if you're freelancing because it's time is.
Exactly. Sir, Surya Prakash, sir, I want you to answer this. Why I am suddenly seeing multiple infections after URS and RARS in my center? There is a crop of urosepsis patients in my center the past 2 weeks. What should I do now?
Yeah, I think Dr. Karthikeyan, we have to talks what the Pritik and Kawaljeet has told. Most important is peeling. We have to go back and see how the people, the new staff has joined. Most important, the pre-cleaning, what they have stressed. I think we have to, the cycle of pre-cleaning, enzymatic cleaning, rinsing, drying, if all these steps are followed, then we think of other patient causes. Are we dealing with some kind of different kind of stones, infected patients? And how are we reusing their disposable scopes too many times? That's what I feel.
Okay, Kritik, sir, you have raised your hand. Yes, sir.
Mainly, we need to maintain a log. We used to know which scope is used for which patient. And if you know a particular scope is causing infection, then probably one of the cases we took a swab from the tip of the scope and it showed a growth. So we probably replace that scope. And so that will be helpful actually.
Yeah, Keshav, sir?
The important thing is in the high level disinfection, when you're using Sidex, when you do pre-cleaning, you have to dry the instruments before you immerse it again. If you don't dry the instrument and keep the wet instrument again, it's not going to be good in disinfection at that time. So important is that you should dry the equipment and then immerse it in Sidex again.
Very
Which
valid
generally
point, sir.
people don't do. They just wash, rinse it, and then put it into Sidex.
Very valid point, sir. Another thing, after putting in Sidex, we don't wash with sterile water or RO water as described. Most people wash in a normal saline, they will cut open a saline bottle and wash it. Most people don't do it with RO water. Kawaljeet Singh, you want to add anything, sir?
Yes, the point that Keshav sir raised is very valid. And second point that I wanted to highlight is the actual contact time. Many a time our technicians in OT in a very high turnover center, they are under pressure. They quickly come on, the case is ready. Quickly take it. They take it out of the Sidex or a Parasafe before the actually the contact time is over. So that is also one of the factor. And third is because of are we maintaining the SOPs, like how often, what is the time duration of this HLD that is used? Many a time it might be expired, it might be beyond 12 to 14 days. So all these factors can cause the infection risk.
Got it, sir. Surya Prakash, sir?
I have a question to Dr. Kawaljeet. See, normally what we do is we do pre-cleaning, then we store the instrument. We don't do high-level disinfection before storing. So when we want to do the procedure, then we put the instruments in the high-level disinfection, then put it in normal saline, and then we use it, rinse that high-level disinfectant. But as per his, like what he told, that do high-level disinfection, dry it, and then store it. Are we doing this kind of practice?
So that is once we are finished with the case, like it is like I told about all the 8 steps that we need to follow, and we need to then store it for the next procedure that we are supposed to follow. So this is what we are doing. Like, I mean, you finish with your case and you go for the cleaning and rinsing and all, then put it again into the, this is what we are doing. We are putting it again into the Cytex. And after that, we are drying and putting in the cabinet that we have specifically in our teas.
So
Yeah.
then
Got it, sir.
you put it in high-level disinfectant when you want to use it again?
That we have already prepared it, and the next day when we are coming for the case, then again we are putting it and taking it out and using it up.
Okay, so before and after the case, you are putting in high-level disinfectant.
We are doing it, yeah.
Okay.
Okay. So if anything like this happens, we just have to discard whatever sterilized instruments already are there. We don't have to go through the same processed instrument. We have to go and check the sterilization logs, and we have to identify any breach in the sterilization cycle, maybe in the storage or something. Sometimes the pre-sterilized stents may be the cause. So we have to discard those kind of stents sometimes. So this is not an uncommon situation to deal with. Dr. Abhishek Singh, can you take on this? Repeated immersion of the receptoscopes in Sidex, we are seeing sparking and insulation failure. Is it the cause for it?
So basically, by and large, the only dipping it into a high-level disinfectant doesn't damage the scope per se, or doesn't damage the ceramic tip, which can potentially lead to sparking, etc. It is only the wear and tear of instrument, and when in those crevices these substances go, and then they can be potentially inflammable. So if there is no break in the continuity of the surface of the instrument, there is going to be no problem. But if you have failed to inspect a broken instrument, then these problems can happen. So whenever you are using a high level disinfectant, the onus is on you that you make sure that the instrument does not have break in the continuity of the surface or coating. If
Okay.
that is true for that this is just an example that it can show sparking, but the infections can also be there due to that. It can harbor protein material. So you have to inspect the continuity of the sheath.
So in
Whatever
that
that
case, ETO may be better if there is a repeated use.
So actually, Dr. Karthikeyan, this is an extremely controversial thing, but the truth is that if you are using high level disinfection and you do not have a standardized SOP, if you are not maintaining the logs, then it will be very, very difficult to justify yourself in the court of law. So
Okay, got
therefore,
it.
whenever you are using high level disinfectant, what is, if you are saying that I used say I used Sidex, what is the proof that you used it for 20 minutes? How do you justify in the court of law or medico-legally that you follow, unless you have a documented SOP and it is you maintain the logs, they are regularly signed by the appropriate personnel, then you cannot defend yourself.
Got it. Rahul, sir?
I just wanted to add one point here. See, high level disinfection, now people are using Parasafe also. So which is a very high level and which is very corrosive in nature. If you put your instrument for a longer time, you will find that it starts to break the surface of that is the coatings of this thing. So you have to be very particular with Parasafe, a thing like Parasafe vis-a-vis Sidex. Sidex we have been using for age immemorial now. So to consider that Sidex will cause sparking of the instruments and other things is, I don't think that is a cause, because it has been used since my father's day. And I would like to say like that. But these new ones, you have to be very particular about thing. And the second cause of sparking and things is the disparity between the type of loops we are using. If you are using a local made loops, then you know that the attachment is not very good, and that leads to a small amount of leakage, sparking, and then that gets aggravated. Sidex as such does not cause it, but yes, Parasafe and other things, they are newer ones, and if you keep the instruments dipped for long, they can cause damage to flexible as well.
Yes, sir. Got it. So as per company people, putting it Sidex is the reason for the damage of the receptor scope, sir. Keshav, sir?
Karthi, there are two practical points. One, for the roaming urologist, when you go to a center, please check when the Sidex was activated. There is a duration of time when it can be activated and used. So you should ask the staff nurse, is it still in the period of validity where it is activated? Second, there are indicator strips. There are strips which come for indicators which say that the level of disinfection is good. There are indicator strips which you can use.
True, sir. Very true, sir. Actually, the staff should write the date of the opening of the Sidex. Most people don't do that. They will keep on using it. Okay. The next question. Rahul, sir. Can laser fibers, stone baskets, graspers be safely re-sterilized if they are labeled as single use? They have been labeled as single use, but we are using it again and again. Is it okay after sterilization? Rahul, sir, are you there? Okay, Kawalji sir, can you get this question? Can lasers, graspers, and baskets be reused if they are strictly single use?
I guess they can be, but again, in the court of law, we will not be able to justify if we cause something with this, because they are labeled as, and manufacturers labeled them as, and in practice, I guess we all are using it in the all practical purposes.
Okay, Dr. Abhishek Singh.
So Dr. Karthikeyan, all reusable, all disposable material can be reused, provided you have a reuse policy. The hospital should have a reuse. This starts right from guide wire and guide wires, ureteric catheters, your baskets, access sheets, everything. But you should have a reuse policy. So this is similar thing is true for cardiologists when they are doing intervention and they are using wires. So you should have a reuse policy. That means that each, say for example, a Teramo wire, the Teramo wire is going to be used for 2 times or 3 times, whatever is that is your reuse policy. How are you going to sterilize this? That is it. How are you going to inspect it? How are you going to maintain the log? If you have this the reuse policy in place, then you are safe in court of law. Then even if your guide wire breaks inside, you have a reason to tell that this is our reuse policy, and this is based out of the institutional experience. The same thing is true for disposable ureteroscopes. If somebody sells a disposable ureteroscope, leave apart companies like Biorad who are not selling it like a disposable ureteroscope. What they say is that this is a limited use. They are not using the term disposable. But there are companies like HugeMed. For them, the scope is disposable. So once somebody says disposable, then if you don't have a reuse policy of your institution, and you then you have a legal binding not to use it again.
Okay. And if you are able to follow the manufacturer's reprocessing steps, then it may be accepted.
For these products, there will be no manufacturer's guidelines because they are single use. A harmonic handle or a ligashore handle cannot have a reprocessing guideline because they don't allow reprocessing. We are reprocessing it.
Got it.
Why are we reprocessing it? Based on our institutional experience, and it is the institutional infectious committee which has to be informed, and then you have to generate a reuse policy. Like we have a reuse policy at MPUH. Many Apollo hospitals, basically this is started from Apollos. Apollos have a reuse policy.
Okay. And Balagopal sir, the next question is also for you only. How often should biological indicators should be checked?
So this the biological indicators should be checked, no, every time you do it. Biological or the chemical indicators should be used every time you use it. And so every time, the chemical indicators, they go with the packet, the urine sterilization pack that you have. It is sent either stick to the inside or the outside of it, and the biological indicators should be inside that, and it should be checked every time.
And especially when any major instrument repair is done, we have to do this sterilization and check it for biological and chemical indicator. Right?
Yeah.
So
Break.
we have a few minutes left for the thing. Rahul sir, how can smaller hospitals implement quality assurance? I have a 25-bedded hospital. How can I assure quality? How can I implement quality assurance? Rahul sir, Rahul Gupta sir.
Sorry.
Yeah.
Well, see, like what Abhishek said, it is in India, we have a broad spectrum of practice. One is institutional practice. One is Dr. Keshav said rooming practice. And that is the reality of India. When we started our careers, we also went to, a lot of places. And you cannot imagine how much eyes and mouth and, we have to keep everything closed if we have to survive that practice. So if you ask me what is quality assurance and what stands in the court of law, what Abhishek said is absolutely normal. And it should be the norm that you should maintain a logbook. There is a differentiation. You should put a lot of money into sterilization, because that is what is going to have a turnover. For a urology, 10-bedded hospital is more than enough. There is no procedure which will keep the patient in the hospital other than some major laparoscopic surgery or a transplant for more than 48 hours in a hospital. And if you're getting a spurt of infections and things, then it becomes very difficult. So quality assurance is by the turnover, the patients, you will know that you are doing a good job. You will know that your sterilization is doing well. When you stop your antibiotics on time for the patient, empirically everybody gives, but when you're stopping it after 3 days or 5 days, you have done a good job. And quality assurance is by you have to maintain a good logbook to protect yourself in the court of law. There is no taking back on that. And that logbook, sometimes the inspections happen, the people would come inside and see that. So, and use, if you're a high turnover institution or a place, then you should try and change over even before SIDEX, like 21 days. Don't keep it for 21 days if your workload is very heavy. And if you've done a contaminated case in between, you've done a pus case or a bad case in between, you just go down the line and change it immediately. Don't wait that somebody is given 21 days. It will not give you protection. Sterad,
Okay.
very good thing, but how many of people can afford? How many people can run it in an appropriate way is always a question. But if you can, no doubt about it, it is what is going to give you this thing. Train at least 2 people in the OT with a good suction, so that teach them how to clean it. If you clean your instruments immediately after the procedure, and I have seen Dr. Madhu Agarwal. I remember once my DNB was over, so I had gone to learn hypospadias. In MPUH, hypospadias not done very popularly. So I went to this thing and I saw Dr. Madhu Agarwal washing his nephroscope and his Alken rods himself. So I was a bit surprised. He's such a senior person, and he told me that any patient gets an infection after PCNL, so I am not in a good this thing. So he washes himself, he dried himself and kept himself. So wherever institution is there, you can always train 1 or 2 people, and only that can give you. Your patient goes home, he does not call you back for dysuria or fever. You've done a good qualitative.
Great, valid point, sir. Dr. Surya Prakash sir and Keshav sir, the last question we can take and then you can complete, sir. What documentation is legally important?
Yeah, Dr. Karthikeyan, before I answer that, I just want to add to what Dr. Rahul said. In institution like Puttaparthi Satyasai Institute, the residents have to take the instruments and put in the SIDEX, and after the case, they have to wash. So everything is done by the residents. So they know how to take care of the instruments. So my question to any of the panelists can take, what is your take on use of formalin tablets? Still, many hospitals, you see instruments like guide wires, uric acid being kept in boxes containing formalin tablets.
It should be absolutely condemned.
Yeah.
It should be absolutely condemned, sir. In fact, in fact, sir, it is for all of us who do.
कागज दिखाओ
Yeah.
कुछ भी मेरे को है नहीं
For all of us who do roaming practice, especially procedures like flexible ureteroscopy, we should move in the direction that there are central sterilization units in every city. See, every steroid needs to be financially viable. So they will, because a cassette of steroid is 5,000 rupees. So they will be very, very happy to do sterilize your instrument at a charge and give it back to you. Just find that central unit, give your instruments there. If you have two flexible ureteroscopies in a day, it is a very, very easy thing today because you buy a set of 3 or 6 generally from the vendor. So you can keep all of the 3 ready with you in a sterilized format. If you have 3 in a day, do 3 in a day. And then you can keep them using over and over. So don't even you can use this for guide wires. You can if the steroid is costly, you can use ETOs. ETO also turnaround time is only 6 hours now, 6 to 8 hours. The drying time has significantly gone down. But don't use something like formalin tablet. The one UTI, the cost of using meropenem for 14 days for this patient is huge, is absolutely huge. There's no justification for using formalin tablets.
Thank you, Dr. Abhishek. But I found that if you use guide wires in ETO sterilization, the life goes out. You see that the outer coating just peels off if you use ETO.
That's what it is, no, for the guide wires and the access sheets.
Yes.
What Abhishek told about the reuse policy is that is what each hospital should have, a reuse policy. And probably, for the lasers, definitely in a hospital, there is a reuse policy. But like guide wires and access sheets, it's the repeated uses can definitely, the coating and then it's a problem.
So if you
Even
want
after
to
the
use
first
guide,
use.
sorry, sir. Yes, sir. If you want to use guide wires for in a time immemorial, that is when I was used to do private practice out of KEM, I used to take one guide wire out of KEM and try to use it over and over because I had got it from KEM and now I don't have to buy another one. So I understand that pressure of private practice is there and it is there equally on everybody. But then it is high time that we understand that this is we trying to save some money might cost us a lot.
That's what I'm saying, that guide wires and access sheets should not be reused. The quality goes down.
No, it's not possible, Dr. Balgopal.
Not possible, sir. Not possible.
Not possible.
India, not possible. Ideally, yes. See, I'll tell you, there was a chief minister, na, somebody called him, sir, आप जाते हो chaos हो जाता है traffic में. कहता, I would love not to use Z plus security, but it's not possible. It's
with
a
access
protocol.
sheet,
It's very unfortunate. What you are saying is ideal. I would love to do that. The quality of surgery also improves with that. Not even that. The quality of surgery improves. You go very easily inside out, but it's not possible not to use an access sheet and not to reuse the guide wire.
The guide wire definitely should not be used. Access sheet, yes, probably 2 or 3 times, but after that it becomes difficult.
Keshav, sir?
Sometimes it gets stuck.
Commonly, how do the people sterilize the laser fibers?
They will take the sterlium and wipe it as the tip
That's
and use.
sterilium, sir. Sterilium is the only way to use the fiber, sir.
No, everybody would do only that. I've
Yes.
seen in workshops everywhere. They
Yeah.
just take some sterilium in a gauze, wipe it, and give it to you, and you happily use that laser fiber.
That is like Ganga gel.
Sir, but ideally, again, same thing. If it is a reuse, because there are 2 types of laser fiber. Laser fibers can be multi-use laser fibers. There are multi-use laser fibers that are available. Fibers like for example, if you take a Moses machine. Moses machine has 2 types of fibers. It's a single-use fiber and a reusable fiber. So reusable fiber you can sterilize. You can do a ETO or a steroid for that. The problem
How many fibers will you keep?
No, sir, how many?
There are 5, 6 lasers which I have to do. So there's going to be time lag.
No, sir. If you are in an individual practice institution, you should have a steroid. Institution, it's a separate thing. I understand that we have not got to a point that we do it consistently. But if you're in an individual practice, if you have how many cases you have, 2 cases, 3 cases, then you have those pieces of say have two fibers and alternate them, use to get them sterile and then use it. This can be one of the ways of doing it. I totally understand that there are compulsions. Everybody may not be in a privileged situation, or everybody may not be in an institution. But if you at least if you think on these lines, you know that there is a central place where you can get your instruments or disposables sterilized. You'll at least once in a while do it. At least you'll do it that today, tomorrow you have a VIP case, you'll do it for that. At least that is possible.
Yeah. But having steroid is a luxury. You can't invest so much money in individual practice or small time nursing homes, especially from Johnson & Johnson. It costs somewhere from 50 to 80 lakhs. ETO is, I think, any institute can buy, where you can get for 4 to 5 lakhs.
Yes.
Yeah.
I think we have reached times, the panelists, elite
The last
panelists.
question you were asking, Karthik? There was a question, last question.
No, sir, what documentation is most important?
I think
In terms of legal.
Abhishek, you can take that question.
So basically, first documentation is what is your standard operating protocol. You should have your standard operating protocol laid down. If you are applying for something like JCI or other accreditations, you already need these kind of SOPs. So you have your SOPs in place. Plus, then your your reuse policy should be there. Your sterilization policy should be there. Once these policies are there and their logs are maintained, you are clean. You are absolutely clean. Every instrument, if somebody alleges that patient developed infection because of break in sterilization, then you have all these documentation to counterfeit it.
Excellent. Surya Prakash sir, is there any questions from the online delegates?
Just a second. Yeah. There's a question from Dr. Sanjay Natarajan. How many of us are comfortable submerging the TURP working element in Sidex versus parasitic acid? Karthikeyan, would you like to answer this?
Yes, sir. I was doing it some 5-6 years before putting the. I used to put the access my receptoscope in Sidex, but my receptoscope started having that firing issue. And the first thing the company person told is it is because of I put it in the Sidex. After that, I purchased a new one. That was completely ETO. Even then, after 2 years, it also got the same problem. And the company person said the same answer, but later on we understood it's because of the wear and tear, small cracks in the thing rather than the Sidex is the cause. I am not comfortable in putting in Sidex.
Okay. Another question from again Dr. Sanjay Natarajan. How do you sterilize high frequency cable and light source cable between the cases?
In between cases, only sterlium or sterlium is possible. Otherwise, as Abhishek said, we need to have 2-3 sets of light cables, ETO in, and then use it.
Okay. There is a question from Dr. Harshit Tayal. This is a good question for scopes when you use for patients who are HCV, HIV, and HBsAg positive. What precautions you take? Extra precautions, or is it like same for any other patients?
Balagopal sir.
It's the same like for any other patient. No, basically, these are all viruses, prions that are there. It's the same precaution that you have to do. It should be a highly sterilization. Instead of dipping it into the Sidex or the parasitic acid, it should be properly cleaned, properly dried, and then you should either ETO or sterile those instruments.
So the duration of Sidex is same, 30 minutes, 20 minutes.
I'm not saying about the Sidex it's the same, 20 minutes or. But what I would suggest is that all these patients, these scopes, they should either be, you have an HCV or an HIV patient should be added. You are safer to have ETO or a sterile sterilization.
Yes, sir. They should undergo sterilization. HDL will not be adequate.
Not work.
Not be adequate, and God forbid if some problem happens, it will be very difficult to defend. So you have to sterilize this instrument. All the scopes should be sterilized after they've been means you have operated a highly contagious infection and you are aware of it, like HIV, HBsAg, and HCV. So there is no getting away from it. And if it's a TURP or a rod lens thing, just autoclave it. Don't shy away from autoclaving a rod lens. It is perfectly okay to autoclave a rod lens. It is written on the scope, it is autoclavable. So
whenever possible, use disposable scopes and disposable drapes, everything
yes.
disposable. And Kawaljeet sir, you want to add something?
I agree with the use of disposables, but I tell you, I was going through CDC guidelines. CDC guidelines clearly state that there is no separate protocol for HIV, HBs, and HCV, and the protocol for using high-level disinfection is same as for any other normal case. So same contact time, similar, no difference with the viral load. Yeah.
Yeah, but what has happened, Dr. Kawaljeet, there generally speaking, CDC has gone away from HDL for ureteroscopy. So they would say that what is the standard of care for flexible ureteroscopes? They'll say sterilization only. In a situation, the statement reads that in a situation where sterilization may not be possible, that is the situation where you will be using high-level disinfection. And it does not see that it just does not apply to their settings because there is no question of reusing the scope. Single use ureteroscope, there is no question of reusing it in a CDC setting. So this is basically our problem.
Yeah, I agree with Abhishek, because in Western countries, you have every day there will be a list for all those hospitals will have a list of the stent removals. So each patient will have a separate flexible cystoscope. It is a separate set that comes. So I think for them it is the HDL is not there. And I think for us also to consider in these highly contagious infections that can happen, we should probably consider sterilization rather than high-level disinfection.
Okay.
Surya Prakash sir, okay, can we?
A question from Dr. Sunil Gaur. I think we answered this about the use of formalin chambers. I think Dr. Abhishek has answered this. And I have one practical question. We have got so many brands of glutaraldehyde available in the market. We always talk about Sidex. I think is it from Johnson & Johnson?
Yes.
But so many other brands if you go to ask a dealer. So are all brands are same in their efficacy, or is there any difference among the different brands? Anyone can take this question. Because I'm running, but it just started. So when I ask Sidex, I get something else which I've not heard of that name.
So it's just it just comes to again brand value. Why you want a suture from Ethicon rather than anybody else? It is like that. Yeah, means it's like Ethicon versus Lotus in terms of sutures. So it's like a brand reputation. Otherwise, that product may be as good.
Okay. Fine. Thank you. I think there are no other questions, Dr. Karthikeyan.
Yes, I thank all the panelists for their excellent presentation and wonderful engaging discussion. I hope it's a very useful webinar for everybody. I thank ISU and USI for this opportunity.
Keshav sir, concluding remarks.
Thank you. Thank you, all of you. It was a good discussion at the end, practical discussion and points. So important lessons learned. Thank you very much.
Thank you, sir.
Thank you.
Uttam sir is there? Yeah, okay. Okay, then thank you. I thank all the speakers. It was a very wonderful practical discussion. All the audience also have joined. Thank you. Thank you very much. Whoever has missed it, they can watch this program again on the e-learning platform. Thank you. Thank you so much.
Thank you.
Good night. Bye.
Good night, everybody.
Bye.
Good night. Thank you.